Question 1. In light of recent developments, staying updated with technological advancements is critical for an RVT. Which of the following best demonstrates the appropriate response to a newly introduced Doppler imaging feature in a high-frequency transducer? A. Continue using older protocols until official approval is granted by the department head. B. Immediately integrate the feature without further assessment. C. Evaluate the new feature's performance through comparative studies and professional training. D. Avoid using new features to maintain procedural consistency. Answer. Correct answer, C. Explanation. The appropriate response to technological innovations is to assess their clinical utility through comparative evaluation and formal training, according to the Intersocietal Accreditation Commission (IAC) NSPU practice guidelines. Staying current means engaging with continuing education, integrating evidence-based enhancements, and validating their impact on image quality and diagnostic accuracy. Blindly implement. B. Or rejecting. D. New features can compromise care. Waiting for department approval. A. Without assessment delays innovation and limits clinical effectiveness. Question 2. A demonstrated by clinical adaptability RETs often encounter patients with severe contractures, obesity, or post-surgical limitations. What is the most appropriate adjustment when faced with a patient who cannot be placed in the standard supine position for a lower extremity venous duplex scan? A. Cancel the exam and reschedule once the patient can be positioned properly. B. Attempt to perform the scan despite suboptimal conditions. C. Use reverse Trendelenburg or lateral decubitus position to enhance venous filling and access. D. Substitute the duplex scan with a non-imaging test. Answer. Correct answer, C. Explanation. Adaptability is essential in ultrasound. The AM practice guidelines encourage alternative positioning such as reverse Trendelenburg or lateral decubitus to optimize venous return and facilitate imaging. The cancelling A may delay diagnosis and proceeding without adjustment. B. Risks non-diagnostic results. Substituting with non-imaging tests. D. Without indication limits diagnostic specificity. Are expected to apply clinical judgment and technique modifications for quality care. Question 3. Given the circumstances, Mr. Alvarez, a 54-year-old male with liver transplant follow-up, is undergoing a hepatic artery and portal vein duplex scan. What Doppler feature would most likely indicate hepatic artery thrombosis? A. Elevated peak systolic velocities with spectral broadening. B. Absent hepatic arterial waveform with tardus parvus in intrahepatic branches. C. Reversed flow in the portal vein. D. Triphasic waveform in the main portal vein. Answer. Correct answer, B. Explanation. Hepatic artery thrombosis, especially post-transplant, manifests as absent flow in the hepatic artery and a tardus parvus waveform in intrahepatic branches due to collateral recruitment. According to Oswald and radiology consensus on transplant imaging, these findings are diagnostic hallmarks. Reversed portal flow, C, may suggest portal hypertension, not arterial thrombosis. Triphasic portal flow is normal. Elevated velocities, A, suggest stenosis, not thrombosis. Question 4. Considering the evidence, what is the key duplex ultrasound finding consistent with chronic mesenteric ischemia in a symptomatic patient? A. Monophasic waveform in the inferior mesenteric artery. B. Peak systolic velocity 275 cm in the superior mesenteric artery. C. Triphasic waveform in all mesenteric branches. D. Reversed diastolic flow in the celiac artery. Answer. Correct answer, B. Explanation. According to SVU guidelines and ARPM's exam standards, A 175 cm in the SMA indicates 70% stenosis, supporting the diagnosis of chronic mesenteric ischemia. Monophasic flow A is non-specific. Reversed flow in the celiac artery. D may suggest compression. E. G. Mals, not ischemia. Triphasic waveform. C implies normal perfusion. Combining velocity. Postprandial symptoms enhances diagnostic accuracy. Question 5. During the process of assessing Mr. Jenkins, who presents with long-standing leg edema and previous DVT, which duplex finding is most suggestive of chronic venous insufficiency with post-thrombotic syndrome? A. Phasic venous flow with respiratory variation. B. Non-visualization of veins due to obesity. C. Reflux duration 1 second in deep veins during augmentation. D. Compressible veins with brisk augmentation response. Answer. Correct answer. C. Explanation. Chronic venous insufficiency, particularly post-thrombotic, is identified by prolonged reflux, ones in deep veins upon augmentation or Valsalva, as per SVU venous reflux testing guidelines. Physicity A. Incompressibility. D. Suggests normal flow. Non-visualization. B. Is a technical limitation, not a diagnostic finding. Persistent reflux indicates valvular incompetence from prior thrombotic. Question 6. To better understand the hemodynamic implications of venous reflux testing, which of the following methods is essential to standardize reflux detection in the great saphenous vein? A. Augmentation with distal compression lasting less than 0.25 seconds. B. Use of Valsalva maneuver in the reverse Trendelenburg position. C. Gentle compression directly over the saphenofemoral junction. D. Patient lying supine with knees elevated. Answer. Correct answer. B. Explanation. Proper reflux testing requires the patient in a standing or reverse Trendelenburg position to encourage venous distension with the Valsalva maneuver to assess valvular competence. According to AM and SVU protocols, distal augmentation may not reflect reflux accurately. Supine position D reduces hydrostatic pressure. Gentle compression over the SFJ C is used for mapping, not reflux assessment. Question 7. Mr. Green presents with erythema and tenderness along a palpable cord in the lower leg. What is the most likely duplex ultrasound finding in this case of suspected superficial venous thrombosis? A. Fully compressible superficial vein with normal color flow. B. Non-compressible vein with echogenic thrombus and absent color flow. C. Reversed flow within a varicosed vein. D. Incompressible deep vein with collateralization. Answer. Correct answer. B. Explanation. Superficial venous thrombosis is characterized by a non-compressible superficial vein containing echogenic thrombus and absence of color spectral Doppler flow. As per SVU guidelines, this helps differentiate from EVT. Option A suggests a normal vein. Reversed flow C might occur in reflux, not thrombosis. Option D describes DVT or SVT. Accurate diagnosis guides management and prevents extension to deep system. Question 8. From a historical standpoint, vein mapping for dialysis access typically includes which key feature to qualify? A superficial vein for fistula creation. A. Vein diameter 2.5 mm with tourniquet. B. Presence of arterialized flow at rest. C. Depth 2 cm from skin surface. D. Absence of perforated veins. Answer. Correct answer. A. Explanation. Per K-Doki, Kidney Disease Outcomes Quality Initiative guidelines, a superficial vein 2.5 mm with tourniquet application is considered suitable for arteriovenous fistula creation. Arterialized flow. B. Appears post-fistula. Depth 2 cm. C. Makes cannulation difficult. Perforated veins. D. Are not exclusionary but require consideration. Preoperative vein mapping is for vascular access planning. Question 9. The underlying principle of differentiating vascular pathologies on duplex imaging depends heavily on spectral waveform analysis. What waveform feature best differentiates a high-grade arterial stenosis from a chronic occlusion? A. Elevated peak systolic velocity with aliasing. B. Absence of flow with monophasic waveform distal to the site. C. Tardus parvus waveform proximal to the lesion. D. High resistance triphasic waveform throughout the artery. Answer. Correct answer. A. Explanation. A hallmark of high-grade stenosis is elevated PSV with turbulent, often aliased flow seen at the narrowing site. SVU criteria support this for quantification of stenosis severity. Occlusions show absent flow. B. And collateral patterns, not aliasing. Tardus parvus. C. Is distal to, not diagnostic of stenosis. Triphasic waveforms. D. Indicate normal resistance, not pathology. Question 10. In the modern context of vascular sonography, what principle of ultrasound physics most significantly governs the axial resolution capability of a transducer? A. Wavelength. B. Beam divergence. C. Lateral gain compensation. D. Pulse repetition frequency. Answer. Correct answer. A. Explanation. Axial resolution improves with shorter wavelengths, higher frequencies, as they produce smaller pulse lengths. As explained in physics principles, this allows distinction of structures along the beam axis. Beam divergence. B. Affects lateral resolution, lateral gain. C. Adjusts brightness, not resolution. PRF. D. Affects Doppler sampling, not axial detail. Mastery of resolution principles is crucial for optimization. Question 11. A 67-year-old woman with a history of smoking and hyperlipidemia presents for carotid duplex ultrasound, which finding most likely represents a 70% internal carotid artery stenosis. A. Peak systolic velocity of 190 centimeters with end diastolic velocity 100 centimeters. B. ICACA ratio of 1.5 with turbulent flow. C. Peak systolic velocity of 120 centimeters with laminar waveform. D. ICACA ratio 4.0 with spectral broadening. Answer. Correct answer. D. Explanation. ICACA ratio 4.0 with spectral broadening in ESV 230 cm suggests a 70% icostenosis based on a strict consensus criteria. Low PSBA, B, and C do not reach this threshold and suggest either 50% or moderate disease. The combination of high PSV, end diastolic velocity, and turbulent flow confirms severe stenosis. Question 12. In the evaluation of a dialysis graft using duplex ultrasound, which of the following best indicates significant stenosis within the graft? A. Peak systolic velocity 100 centimeters. B. PSV ratio across stenotic segment 400 centimeters with post-stenotic turbulence. D. Uniform color flow without aliasing. Answer. Correct answer. C. Explanation. A full PSV 400 centimeters and post-stenotic turbulence is consistent with a 50% stenosis according to SVU guidelines on dialysis access graft surveillance. Low PSVA indicates low flow, A ratio on 0.5. B suggests no significant narrowing. Uniform flow. D does not support significant disease. Question 13. A patient is referred for an upper extremity arterial duplex due to symptoms of digital ischemia. What finding is most indicative of subclavian steal syndrome? A. Bidirectional flow in the vertebral artery. B. Normal triphasic waveform in the subclavian artery. C. Elevated brachial pressures on the affected side. D. Increased resistance in the common carotid artery. Answer. Correct answer. A. Explanation. Subclavian steal syndrome is diagnosed when there's retrograde or bidirectional flow in the vertebral artery, suggesting subclavian artery stenosis occlusion proximal to the vertebral origin. This steals flow from the cerebral circulation. Normal triphasic flow. B excludes the diagnosis. Increased pressures. C are unlikely. CCA resistance. D is unrelated. Question 14. Which technique provides the most accurate assessment of residual thrombus in a previously thrombosed deep vein during follow-up? A. Color Doppler signal alone. B. Spectral Doppler velocity comparison. C. Compression ultrasound with grayscale imaging. D. Use of patient-reported symptoms. Answer. Correct answer. C. Explanation. Compression ultrasound with grayscale imaging remains the gold standard for assessing residual thrombus and vein wall changes. According to and SVU, compressibility directly reflects thrombus presence or resolution. Color alone A. May miss partial occlusions. Symptoms D. Are non-specific. Spectral velocity B. Is supportive but not diagnostic alone. Question 15. A patient undergoing lower extremity arterial duplex is found to have a tardus parvus waveform in the distal superficial femoral artery. What is the most likely underlying cause? A. Distal embolic occlusion. B. Proximal iliac artery stenosis. C. Arteriovenous fistula. D. Deep vein thrombosis. Answer. Correct answer. B. Explanation. A tardus parvus waveform, low amplitude, delayed systolic upstroke in the distal SFA indicates a hemodynamically significant proximal lesion, often in the iliac artery. Its pattern reflects reduced inflow. Embolic occlusion A would lead to absent flow. Fistulas C show high diastolic flow. DVT D affects venous, not arterial waveform. Question 16. What duplex ultrasound finding is most characteristic of an arteriovenous fistula? A. Reversed flow in distal veins. B. Triphasic waveform in the draining vein. C. Elevated diastolic flow in feeding artery with turbulent venous waveform. D. Pulsatile venous flow with low resistance arterial waveform. Answer. Correct answer. C. Explanation. An AF demonstrates elevated diastolic flow in the feeding artery due to continuous runoff and turbulent venous waveform from high-velocity arterialized venous return. This finding is a key duplex hallmark. Triphasic venous flow. B is abnormal. Reversed flow. A may indicate obstruction. Pulsatility in venous flow. D may occur but is not specific alone. Question 17. During a transcranial Doppler TCD examination, which of the following findings is consistent with vasospasm following subarachnoid hemorrhage? A. Peak mean velocity 120 cm with Lindegaard ratio 3. C. Absence of diastolic flow in the emachi. D. High resistance waveform in the vertebral arteries. Answer. Correct answer. B. Explanation. A mean velocity 120 cm in the middle cerebral artery and a Lindegaard ratio 3 emachi velocity is diagnostic for vasospasm per American Society of Neuroimaging guidelines. Low velocity. A rules out spasm. No diastolic flow. C suggests occlusion. Vertebral resistance. D is unrelated to emachi vasospasm. Question 18. What is the most appropriate way to differentiate a pseudoneurism from a hematoma using duplex ultrasound? A. Hypoechoic region with no vascular communication. B. Round anechoic area with internal echoes. C. Tanfero-spectral waveform in the neck of the lesion. D. Color Doppler silence within the lesion. Answer. Correct answer. C. Explanation. A Tanfero waveform in the neck of a pseudoneurism on spectral Doppler is diagnostic and differentiates it from hematoma. Hematomas. A. Show no blood flow. Internal echoes. B. May appear in either. Doppler silence. D. Suggests a vascularity consistent with a hematoma. Question 19. In venous mapping for coronary artery bypass grafting CAG, what is the primary criterion for identifying a suitable vein? A. Diameter 2 mm without compression. B. Superficial depth 3 cm. C. Evidence of reflux. D. Presence of collateral varicosities. Answer. Correct answer. A. Explanation. A vein diameter 2 mm is the minimum requirement for use in CAMG as per SVU protocols. Deeper veins. B. Are harder to harvest. Reflux. C. And varicosities. D. Reduced suitability due to compromised integrity. Question 20. A sonographer performs a duplex evaluation of the popliteal artery and identifies a cystic structure compressing the artery externally with associated reduced flow. What is the most likely diagnosis? A. Pseudoneurism. B. Adventitial cystic disease. C. Baker's cyst rupture. D. Popliteal vein thrombosis. Answer. Correct answer. B. An explanation. Adventitial cystic disease causes external compression of the popliteal artery by a mucin-filled cyst within the arterial wall, leading to reduced distal flow. It is rare but classic in middle-aged males. Pseudoneurism A is pulsatile and intraluminal. Baker's cyst C is typically posterior and does not compress arteries. DVT D affects veins. Question 21. A 55-year-old male with a history of hypertension presents with symptoms of claudication. Which duplex ultrasound finding most likely suggests significant atherosclerotic disease in the common iliac artery? A. Peak systolic velocity of 150 cm with a low resistance waveform. B. End diastolic velocity 50 cm and spectral broadening. C. A AU ratio 2.5 between the common and external iliac arteries. D. A monophasic waveform with low end diastolic velocity. Answer. Correct answer. C. Explanation. A ratio 2.5 between the common iliac artery and the external iliac artery suggests significant atherosclerosis or stenosis. 8.5 is indicative of a 50% stenosis. Option A is typical of a normal waveform. Option B suggests more distal disease. A monophasic waveform D typically occurs with more severe disease but is less specific for iliac stenosis. Question 22. A 45-year-old female presents with a pulsatile mass in her neck. What duplex ultrasound finding is most consistent with a carotid artery aneurysm, A. Presence of a turbulent flow with no stenosis, B. Well-defined cystic mass with spectral broadening and low velocity flow, C. High PSV with minimal spectral broadening, D. Lack of Doppler flow in the mass. Answer. Correct answer, B. Explanation. A carotid artery aneurysm typically appears as a well-defined cystic mass with spectral broadening and low-velocity flow within the aneurysm. Turbulent flow A can also be present, but the cystic nature and low-velocity flow are more characteristic. High PSV C would suggest stenosis rather than an aneurysm. Lack of Doppler flow D would indicate occlusion, not an aneurysm. Question 23. During a renal artery duplex exam, a peak systolic velocity of 350 centimeters is recorded in the proximal renal artery. What is the most likely cause of this finding? A. Severe renal artery stenosis. B. Renal artery dissection. C. Renal vein thrombosis. D. Normal anatomical variant. Answer. Correct answer, A. Explanation. A peak systolic velocity of 350 centimeters is suggestive of severe renal artery stenosis, with velocities above 180 centimeters typically indicating 60% stenosis. Renal artery dissection B might cause a different flow pattern. Renal vein thrombosis C is a venous issue and would not cause high arterial velocities. Normal anatomical variants D would not such high velocities. Question 24. A patient is referred for duplex ultrasound of the lower extremities to evaluate for deep vein thrombus DVT. Which finding is most suggestive of an acute DVT? A. Non-compressible vein with absent Doppler flow. B. Non-compressible vein with a visible thrombus but normal Doppler flow. C. Visible thrombus with compressible veins. D. Normal vein with increased Doppler flow during inspiration. Answer. Correct answer, explanation. In a DVT, the most characteristic finding is a non-compressible vein with absent Doppler flow due to the thrombus obstructing the lumen. Option B suggests the thrombus is chronic or that the clot is partial. Compressibility C excludes DVT. Increased Doppler flow D during inspiration would be normal. Question 25. A 68-year-old male with a history of stroke and hypertension presents for carotid duplex ultrasound. Which finding is most indicative of an extracranial carotid artery dissection? A. Low resistance flow with a very high peak systolic velocity. B. Presence of a flap or intimal tear with an echogenic intraluminal clot. C. Plaque with a smooth surface and well-defined borders. D. Turbulent flow without stenosis or plaque formation. Answer. Correct answer, B. Explanation. An intimal tear or flap with an echogenic intraluminal clot on duplex ultrasound is highly suggestive of a carotid artery dissection. This finding is pathognomonic. Low resistance flow A and turbulent flow D are less specific. A plaque with smooth borders C is typical of atherosclerosis, not dissection. Question 26. A patient presents with a history of chest pain and suspected aortic aneurysm. What duplex ultrasound finding would suggest a true aortic aneurysm? A. Aortic diameter 3 centimeters with smooth, uniform arterial wall. B. Pseudoaneurysm with increased velocity at the neck of the lesion. C. Severe stenosis at the distal aortic arch. D. Arterial dissection with double lumen pattern. Answer. Correct answer, A. Explanation. A true aortic aneurysm is defined as a dilation of the aorta with a smooth, uniform arterial wall and a diameter 3 centimeters. Pseudoaneurysms B show turbulent flow at the neck. Stenosis C would not cause dilation. A dissection D has a double lumen pattern but is not classified as an aneurysm. Question 27. During a venous duplex ultrasound, a patient has a positive Buerger's test with significant arterial occlusion. What is the most likely diagnosis? A. Acute thrombophlebitis. B. Chronic venous insufficiency. C. Peripheral arterial disease. D. Deep vein thrombosis. Answer. Correct answer, C. Explanation. A positive Buerger's test and significant arterial occlusion suggests peripheral arterial disease PAD, which is a common cause of ischemia and claudication. Thrombophlebitis A is superficial and typically presents with swelling but without major arterial occlusion. Chronic venous insufficiency B and DVT D are venous conditions that would not cause arterial occlusion. Question 20. A 50-year-old male presents with unexplained swelling in his legum. A venous duplex ultrasound reveals non-compressible veins in the popliteal area. Which of the following would be most likely responsible for the swelling? A. Lymphedema. B. Deep vein thrombus DVT. C. Arterial occlusion. D. Popliteal artery aneurysm. Answer. Correct answer. B. Explanation. DVT causes non-compressible veins due to the presence of thrombus within the venous system. Lymphedema would present with swelling but not affect venous compressibility. Arterial occlusion C leads to ischemia, not venous swelling. Popliteal artery aneurysms D would present with pulsatile masses, not venous compression. Question 29. A 60-year-old female is undergoing a carotid duplex study for stroke prevention. Which finding is most suggestive of fibromuscular dysplasia FMD in the internal carotid artery? A. Irregular stringer-beats appearance in the proximal ica. B. Smooth, uniform stenosis without post-stenotic dilation. C. Uniform increase in PSV across the carotid bulb. D. Severe plaque formation with evidence of ulceration. Answer. Correct answer. A. Explanation. Fibromuscular dysplasia FMD is characterized by a string-of-beads appearance in the proximal internal carotid artery due to alternating stenosis and dilation of the vessel wall. Smooth, uniform stenosis B is more typical of atherosclerosis. Uniform PSV increase C and plaque formation D are not specific to ME. Question 30. A 75-year-old male with a history of heart disease is referred for a renal artery duplex ultrasound. What is the most likely duplex finding if the patient has renal artery stenosis? A. PSV 200 cm with post-stenotic turbulence. B. Low resistance waveform in the renal artery. C. Increased velocity in the renal vein. D. Normal triphasic flow in the renal artery. Answer. Correct answer. An explanation. 800 centimeters with post-stenotic turbulence is consistent with renal artery stenosis. This finding suggests significant narrowing. A low resistance waveform B would be seen in patients with renal disease, but not necessarily stenosis. Increased velocity in the renal vein C is uncommon in stenosis. Triphasic flow D is abnormal for renal arteries and would suggest another pathology.